what new that we did, or what new thoughts that went into our practice, or what new things we learned in the last 2 years since we had our physical conference last year, the last physical conference. Part of the learning obviously was because we were at home, there were a lot of webinars and Zoom meetings were going on. There was a lot of time for us to do introspection, look at our own things that we did, and try and correct it if possible. And out of that has come this course, which we hope will help us exchange our ideas. And my request to you, after each speaker, please feel free not only to ask questions, but more to share your experiences in connection with the subject that has been discussed. And any query is a good query, so one needn't really hesitate to ask. And with this, our first speaker, fortunately, is a star speaker, Dr. Anaga, who's, sometimes I doubt whether should I call it rising star or risen star. She's a member of ARC committee, a prolific surgeon with a prolific practice, and a multifaceted personality who will be the first speaker. And she wants to share with us what new things she learned in those last 2 years. With this, I request Anaga to start the session.
They're just setting it up, sir. Good afternoon, everyone. And at the outset, I would like to thank Dr. Haldipurkar, sir, for including me in his IC. And yeah. And I would also like to compliment Dr. Haldipurkar, sir, that this is a totally different and a unique topic, because we have all heard of general topics on cataract, refractive glaucoma, but this is something which has been so unique because we have gone through a very unique and a once-in-a-lifetime kind of situation in the last 2 years. So let's see what I have learned from the corona pandemic. Life isn't about waiting for the storm to pass. It's about learning how to dance in the rain. So we all have faced a very overwhelming situation with the entire country going under a lockdown. And yes, as ophthalmic surgeons, we faced also a very unique problem in the sense that our cataract patients, which are our bread and butter, just simply refused to come. One, because the inability to come because of the lockdown, and two, because cataract being an elective surgery, the patients had a very easy option of postponing the surgery. The problem was that because of this, we all saw an overwhelmingly increase in the incidence of lens-induced glaucomas, mature intermittent cataracts, very hard, dense cataracts. So all of us have seen this, and I believe all of us have found this change. Now, nothing in life is to be feared, it is only to be understood. And now was the time to understand more than any other time so that we may fear less. So this was an opportunity for us to hone our skills at the hard and complicated cataracts that we saw. So here you can see, suppose you have an intumescent cataract like this. The first thing is when you are doing a manual rhexis, you can use different techniques because there is a very high incidence of Argentinian flag sign. So here we are using the spiral design. So you refine your capsular rhexis in a way so that you get a good, adequately sized capsular rhexis, but at the same time you prevent an Argentinian flag sign. This was another hypomature intumescent cataract with a toric IOL. So here we are planning a very small rhexis, say a 3 millimeter rhexis in the beginning. The aim is that you first make a small rhexis and then decompress the capsular bag. So here, because the intralenticular pressure is much higher, if you start from the periphery, it very easily runs out to the periphery and you can have an anterior capsular extension. So here you first make a small rhexis, and then I'm actually using an irrigation aspiration to aspirate out some of the loose cortex, and so the bag is the decompressed, and then you have a nice high molecular weight viscoelastic flatten the anterior capsule, and now we have made a nick with a scissors, and with a 23 gauge microforceps, we can extend this. And this gives us now an adequately sized capsular axis so as to facilitate a proper phaco and the rest of the surgery. Now, we also made use of the Zepto technology, which works superb in such cases. And here we are using a multifocal intraocular lens, as you can see, with absolutely perfect centration, and it gives very good visual outcomes too. So we also have access to the flax in our center. So it works well to give very good rexes also in intumescent cataracts. And definitely you can use premium lenses also. So these were the various things that you can actually go at, and we had enough and more opportunity here in case of the COVID times. And yes, all our patients face tremendous problems in their economic conditions and the demand for discounts at every step. The problems that we as surgeons had to face with use of PPE kits, the risk that we were exposed to because of the aerosols, and the RT-PCR tests that we needed to have our patients getting done. So these were too many things, and we had to have really a very brave heart to face all this. So now there was this good, nice paper on will COVID-19 change our thinking about the timing of cataract surgery. And yes, though otherwise we would not have probably thought about this, but in this unique period, probably doing a sequential bilateral procedures, especially for those patients where the coming and commuting to the hospital was difficult, could be one of the options. And yes, we all had the sanitizers, the masks, and the social distancing to be followed. Now, an interesting article here was wearing face masks becoming a higher risk of endophthalmitis, especially in intravitreal injections. And probably this could also, extend to cataract surgery. And the challenges here was basically the dispersion of the airborne particles towards the eye when the patients speak or even breathe. So most importantly, because of the mask, it probably impedes the proper preparation of the periocular area, and there could be a contamination of the surgical instruments with the mask, with the surgeon's glove. Now this is a very interesting picture, and if you can see the three pictures with the arrow, you can see these are the video frames which demonstrate condensation of the breath on the intraocular lens. So this is really scary. So if at all this actually happened or could happen today, even today we are using masks in our ORs. So I think this is something which we need to keep in mind. So what we basically learned is how to tape the face mask onto the patient's mid-face prior to all ophthalmic surgeries, especially the intraocular ones, to reduce air leakage. So learning how to drape is an important art which you should not trivialize. So here you need to dry the patient's skin, press down firmly, and ensure a complete seal with an adhesive tape to prevent the spread of infection. Now again, the cataract service was also redesigned, not only in all over the globe, but also at our center. And yes, there were a lot of webinars. Also as part of the ARC, we conducted a large number of webinars and learned a lot new techniques. If you saw the number of patients who were diabetics, and yes, because all our outdoor activities and even the walking had reduced, there was a high incidence of diabetic retinopathies and the cataracts in post-diabetic patients. So you needed to counsel these patients, and we all remember having such social distancing and wearing of the face shield and all that. So these patients were already so tense and with their economic problems and the complicated cases, our counseling also had to be redefined. Now, if you look at the challenges of wearing face masks, something I would like to share with you is there was not only an increase in the incidence of dry eye, but yes, you will all relate to the fogging of glasses. All of us who are wearing glasses would also relate to it. I would like to share with you a unique mask-related femto-LASIK complication which we had experienced. So if you can see here, how with each breath of the patient, you can see how that steam is going up and down of the breath, and you can see we are doing an intralaser here, but there was no penetration of the femtosecond laser. So the laser actually, we stopped it because it couldn't be completed, and we went ahead and did completed it on another day. And this was also published as an online case report in the JCRS in Jan 22. Now, there are a lot of mask-related causes of the dry eye. The most important is there is increased breath that is coming out from the top of the mask. Yes, using lubricants, ensuring that your mask fits well, and then other environment-related changes that you can make will help. Digital eye strain and ocular surface disease was also on the rise. This was a very interesting article where they compared a face mask-related ocular surface modification along with changes in clinical in vivo confocal microscopy and immune cytology studies. So the purpose of this study was to describe how the face mask actually causes changes on your ocular surface, and the results are really very scary because the mask use is still on today and we never know when the next wave hits us. So what they did was compared a first group of dry eye disease patients, known dry eye disease patients, with healthy subjects, and they divided into 3 groups: less than 3 hours, 3 to 6 hours, and more than 6 hours. And what they found was, at all these patients with the dry eye, especially the T-BART, the fluorescein stain, all of them were significantly affected. So for example, you can see more than 6 hours, you can see how the lissamine stain is also increased. So today we are, as surgeons, we are using face masks throughout the day. So we all need to get our eyes checked for a dry eye workup, I believe. So there was a dendritic cell density and HLA-DR also positivity, which was significantly higher, and a reduction in the goblet cell density too. So these were all actually proven. So this means that we all need to worry and take care about the dry eye patients that we already have. So for all our cataract surgery patients, we started doing a dry eye workup during the corona pandemic, and that was what that we learned. And also modify the surface with medical and behavioral strategies. Detect and treat early was what we learned. Use lubricants and also IPL treatment and monitor them regularly. Even a simple refraction that we did for our post-cataract patients, because of the lens fog, many times they just thought that they were not able to see when actually the trial frame was getting fogged. Even those patients who are on anti-glaucoma medication, you can see that because of the mask, there is not only a fixation loss rate, there are artifacts because of the mask. So we need to be very alert to these conditions, especially in our glaucoma patients too. And all these small things like mask wetting, not only and staining, not only in the OPD but also in the OT, actually could cause small problems to our patients. So the take-home message is we need to be more alert, more aware, not only in our OPD for our high-risk groups of dry eye and our cataract surgery, refractive surgery patients. We need to counsel them, detect early, treat early. So what we learned was to be resilient, which means advancing despite adversity, and we also need to upskill ourselves. So we took that opportunity to upskill ourselves and our staff and our doctors for this. I would just like to share one thing with you, that it's not just being resilient, but also being anti-fragile, where you gain from a disorder and not just bounce back after an event has happened. So never stop learning, because life never stops teaching. Thank you so much. So even as a crisis drove us apart, we healed by coming together. Thank you so much.
Thank you, Anaga. I just want, by the way, my friends, if you all have any questions related to anything, please feel free to ask. I start with the first one. Anaga, you showed Zepto and you showed Zepto real fast. That was very good and very impressive. Tell me cases where you cannot or should not use Zepto?
Subluxated cataract?
So you obviously, and
No.
maybe presence of vitreous?
Definitely. Presence of vitreous we cannot.
But otherwise.
But even in a small people, I've used iris retractors and I've used Zepto.
Okay. What about extremely fibrotic capsule? That's where it is more.
Yes, it will be difficult, but then nothing would work, not even flax. So in such cases, you need a scissors. I mean,
So
even the manual Rexis would be difficult.
But have you ever tried in very fibrous capsules?
So if it's usually in a fibrotic capsule, there would be areas which are still clear. So in those areas, it might cut. But in a very thick fibrotic plaque, it would be difficult. So maybe you can use it as a template and then fashion out the rest of the Rexis.
How many among the delegates or attendees are using Zepto? None. Okay. So you have any questions?
So ma'am, since you found out that there is dry eye that's much more prevalent now, is there any protocol that you have started that, obviously the ones that you have detected dry eye, you would treat them, But
Yes.
otherwise, do you start any lubricant pre-op, and which one you
Definitely.
prefer?
See, especially for our premium IOL patients, if you're planning a toric, for example, and a patient has a poor ocular surface, your keratometric readings are not going to be, perfect. And you need to repeat and see whether you're getting consistent readings or not. You can go completely haywire and you can end up having a residual astigmatism. When you're planning a multifocal IOL, your patients will come back to you with complaints of dry eye, even if you're 6'6" and 6. So more than ever, today is the day when you're going to have a highest incidence of dry eye. So we need to be very alert, especially in these premium IOL patients.
So is there a molecule you prefer to put? As in
Yes, we usually use sodium hyaluronate. That works best. But in cases of moderate to severe dry eye, we have also done an IPL first, pre-op, and especially in the refractive surgery group, I would definitely recommend each and every patient to do a complete dry eye workup.
Yeah. Thank you so much.
Thank you so much, sir.
Thank you. Yeah, please.
Hello.
Yes.
During manual rhexis in mature cataract, you first did a small rhexis and then you debulk and then you enlarge it. So why don't you debulk whole nucleus and then enlarge? Because if something goes wrong while enlarging the rhexis, it will go haywire. So better to do whole lens removal and then enlarge the rhexis.
See,
That
if
will
what rhexis I had shown was quite small, so what you mean to say is to do a complete phacoemulsification and then, if it was a slightly larger rhexis, I would do that. We have done that in certain other conditions, but here I didn't want to go more bigger because then there was a higher risk of going to the periphery. Here, I started and it was planned in such a way that it would be around 3 millimeters. Debulk just to get a flat anterior capsule. See, you cannot go too deep inside the bag also because otherwise it can, pull on the zonules. So here it was big enough for us to decompress and then it becomes a very controlled extension of the rhexis. In case the cataract was not so intumescent and you have a mid-sized rhexis, you can go ahead and do a phaco. And then when you put in the lens also, you can, even after putting in the lens, sometimes we have extended. See, you don't want a capsular phimosis at the end, but at the same time, you want a very controlled phacoemulsification.
My idea is just to enlarge the rhexis after removing whole nucleus. Because, the nucleus anyway is very small in mature cataract. So better to remove whole nucleus and then remove, because if something goes wrong by enlarging the rhexis, it may go in the periphery
Yes.
and then create a problem.
Yeah,
That's
it
what I
makes
believe.
sense. Yes,
Okay.
it makes sense. Yes.
Uh,
Thank you very much.
Thank you. Thank you so much. And now we are privileged to have our second speaker, Dr. Chitra Ramamurthy. She is the chairman ARC, and God has been very, partial to her. He's given her 36 hours in a day and 150% energy than normal people. And that we have seen in the last 2 years, the way she's been up and about, spreading the knowledge for all of us to become more educated. Thank you, Chitra. And today she'll share with us, what she learned in the last 2 years of, a disturbed period. Chitra.
Yes, actually, before I start my talk, the reason why I have got so terrifically energized about it all is I realized that it's not an ordinary responsibility that has been entrusted. I have to do something that you'll remember me after my time. So I would be very happy if you all do watch few of those ARC webinars, remembering that I put my life and soul in it only for all of you. Thank you very much, Dr. Suhas, for allowing me this time. So what I learned new in cataract surgery during lockdown, I did not learn newer surgery, so I'm not showing newer surgical techniques. But I found in our practice that there was a sudden increase in health awareness. We had to just tell them toric IOL and explain they would want toric IOL. We explained Indian multifocal or for imported multifocal based on their cost possibilities. There was an increased generosity in their minds to prioritize for their health. So I thought I would concentrate on telling you how we learned to optimize in getting more premium during this lockdown period. So what is important for us to remember that when we are talking of a refractive cataract surgery, that is getting that kind of visual outcomes in cataract surgery, we need to run after astigmatism, even low diopters. And I'm sure if all of us are already doing it, then we are already there. My talk is null and void. Residual astigmatism about 0.5 diopter or less is probably acceptable, which conventional wisdom tells us. But anything more, definitely let's understand we might have done a great surgery, but the image quality definitely would decline unless you wear those spectacles. 66, if you look at the statistics of the prevalence of astigmatism in cataract surgery, it tells us that 66% have astigmatism between 0.25 and 1.25, and there we need to address it. So then, what becomes important for us to understand is, what is the most common procedure to manage astigmatism with different levels of astigmatism? So this was a way back in 2014, an ASCRS survey was done, wherein they found that there was a 42% and odd who went in for this OCCI or on-axis incision when the amount of astigmatism was low, and then gradually 13.2% or 17% moved on to LRIs and astigmatic keratotomy. Femtosecond laser had also come in a decade ago. But toric IOLs had already started peaking, but at the same time, more beyond 1.25 astigmatism, with more than 53.9% wanting it. And some more got bioptics done if there was some residual ever, and some remained with glasses. In 2021, a survey was done. It showed that 14% of them wanted for toric IOLs, even for 1 diopter, 31% for 1.5, 31% for 2 diopters, and 24% for 2.5 diopters. And this was another study. What was the cause for a dissatisfaction after implanting a multifocal IOL? It was seen that the residual refractive error was the major cause, up to 57%, followed by dry eye, which we have not evaluated. And we got very aggressive in ensuring dry eye was definitely a part of our workup. Fewer in visual symptoms and few in CME or few of the intra-op complications. So then, what was also came to light was the dissatisfaction of vision. That is, the percentage of very dissatisfied to okay dissatisfied at 3 months post-op was essentially the residual refractive astigmatism in the worst eye. And these are your mouthpiece who are going to go around telling you, it told us that run after this astigmatism. If you can get access to any optical biometer, and you're lucky to have IOL Master 700, what has happened with the technological development is it has incorporated a Swift source OCC along with the B-scan, wherein it measures the corneal thickness, the lens thickness, ensures it's always on, bang-on fixation, and a 3-zone keratometry. What it does is it uses a toric model to measure the anterior corneal surface, and with the information of the corneal thickness, it interpolates the details of the posterior corneal curvature and gives you an information of the anterior corneal astigmatism and the posterior corneal and the total keratometry value. And this now gets incorporated in the 4th generation Barrett's formulae, the Barrett's universal and the Barrett's toric to become TK universal, TK toric. But remember, you can't just take this TK value, which you have measured on the optical biometer, and feed it online into any of the other formulas, because they already have a mathematical model to calculate the posterior corneal astigmatism. You would end up overcorrecting the astigmatism. Nowadays, machines have, the biometers have a central biometry, which gives you a very good anterior axial map and a total axial map, which gives you more information about the curvature. The most important thing we all have to come to understand, we have to just bunk the older formulas. The Barrett Universal 2 is there in most optical biometers or is there online. We have to use it because it gives you what we all know is we need to get to understand how close we can to the effective lens position. That is where the lens sits in the bag. If the lens sits a little forward, there is a little less power needed. Let's sits backward, more power is needed. So what these later generation formulas do is they measure many variables. Like here, there are 5 variables which have been measured. It also measures the lens factor. That is the distance between the iris plane to the principal plane of the IOL. So imagine that level of accuracy these formulas try to address to find out where the IOL sits and give you the exact IOL power calculation. Now, if you look at the Barrett suit, the Barrett Universal Formula is a thick lens formula. It's a mathematical model wherein it even tells you the principal plane of each IOL, because the geometry of the IOL changes with the power. It is biconvex to plano-convex to meniscus, so it tells you exactly where the lens would sit in the eye. It also, in the Barrett toric, it will give you information about the with the rule cornea, against the rule cornea, the posterior corneal astigmatism, and take your toric IOL surgeries to a different level. If you have Barrett True K toric, it incorporates, again, a mathematical solution with the double K solutions and gives you, because there's an alteration in the ratio of the anterior and the posterior cornea, so you need this total TK value to be incorporated in this particular formula to get exact. So now, my post-LASIK and post-RK patients, I confidently suggest premium IOLs for them. And if at all there has been an error in a toric IOL, it will tell you with the Barrett RX whether you're going to rotate the lens or you're going to do an exchange or whether you're going to do a bioptic. So we need to identify these patients. Now, if you look here, there is some amount of astigmatism, the total TK value which is there, significant astigmatism is there. So then the next question you will ask, how low would you start putting toric IOL? I would say if it's a with the rule, I would wait to up to maybe 1.25, 1.5, but if it's against the rule, even from 0.4 or onwards, I would tell. In fact, your machines will tell you whether it's a non-toric, like for 0.9 with the rule, it said no toric. Whereas for a 0.88 against the rule, it tells that you use a T3 toric, and that would tell you how to plan. So this is one case which I'm showing you, wherein it is telling you that there is some amount of 0.87 and 1 diopter of astigmatism, and it tells you the different formulae to be used. But what we did at that time, we had PanOptix, but we did not have PanOptix toric. And I thought the astigmatism was less and did a PanOptix for the patient, did a great surgery, but the patient had a small cylinder, and I told him I would do a laser vision correction. But by the time he came to me for the second eye, we had PanOptix toric for him, and we entered it and did the calculations, and he ended up getting 6.6 in that eye, and then further on did a laser vision correction, and he was plano 6.6 in both eyes. Now, this is another case which was planned for a multifocal toric. Again, it is a small cylinder, 0.57 and 0.63. But again, if you feed it into the machine, because if it is an against the rule, it tells you that you need a toric IOL to be implanted. And if your patient is bleeding, we have very good Indian torics which come at a lower price. You could do this exactly and get your patient out. Even against the rule astigmatism, if it was there in this particular patient, what the K value gave us 1.14 diopters. But if you have access to TK, it tells you that it is 0.61 diopters in 140 degrees. So then you realize that you could do a toric IOL for this patient. Then you use your Barrett TK toric mode, and it will tell you how to do it. So essentially, it is very important to do your measurements accurately. Now, this was the second case where the dry eye was there, and then more than 60% of the patient with dry eye are asymptomatic, and we went wrong in our earlier days, and he had a 0.5 astigmatism in the right eye and +2 in the left eye. We should have had those danger warnings, but we didn't look at it, and he ended up implanting a 19 diopter IOL in his eye. The K values were different. It should have struck us that the measurements were wrong because it was a dry eye status, and then he ended up with a +2 diopter. Had we waited, got his dry eye treated, and then done it, he actually would have needed a +15 diopters, and we could have done a better job with this patient. Again, if you have access to central topography, you would know whether it's an asymmetric cornea which you're treating, and that would tell you whether to go in for a regular or an irregular astigmatism is an important information which you get. This is again another patient, which also tells you when those fuzzy LED spots are fuzzy and they're not clear, that would itself be an indication. If your standard deviations are off, as it is showing here, you would also know that this is not the right way you would go into other modalities. In fact, only 70% of our patients, you could use your older formulas, they don't have dry eyes, they may get away with it. But if your SD standard deviation is more than 0.2 or more than 0.03, look for dry eye. If it is dry eye, treat it. Then do your measurements and then do a premium IOL surgery. Otherwise, if the patient has had a refractive surgery or has a KC or a PMD, not a topography, you need to do a tomography, calculate the back vertex, posterior corneal astigmatism, feed it into your toric calculator, use the latest formula, and take care of these patients. In fact, what we do in our practice is, as soon as the patient shows an interest in getting a cataract surgery done, before we touch his cornea, do even an applanation tonometer, we actually do a biometry for these patients, and then and if he has a toric IOL, the direction of discussion altogether changes. Again, with post-refractive surgery, we would the latest generation formulae or the Haigis and more. So in fact, if it is a low diopter of astigmatism, we would do if you have a femtocataract platform, we would do an astigmatic femtosecond arcuate incisions and bail him out of those situations. In fact, what I would like to say is, what I understood is, we need to identify and educate our patients, plan the right IOL for these patients, believe that majority of the patient want uncorrected vision for distance and near. Please measure your corneal astigmatism as accurately as possible, measure your posterior cornea, and always tell yourself that you're going to hit target spherical equivalent at all times. This is what I learned. I wish all of you, if you're already doing it, you have nothing to learn from me. But if you're not there, please get there, because that will take your practice to an entirely different level. And that's what I learned. Thank you very much.
Thank you, Chitra. Very comprehensively, very nicely thought out presentation. I just want to open up the questions. Your practice, meaning your Eye Foundation, was on the forefront with LRIs in the past. Now with the toric lenses having come, obviously LRI has come to the background. But, and now with femto coming in, we have femto arcuate incisions. Now, in which of your femto patients would you offer them toric, or you would stay
do
with
arcuate incision.
Yeah.
Yeah, I said I would feed them all into my biometry, find out the astigmatism, and it will tell us whether they need a toric or non-toric. If it says toric, then I would try to talk to them for a toric. But if they do not want, if it's a small amount of astigmatism and they are not keen, I'm really surprised. Since COVID, they are all keen. I have my whole list doing only premium IOLs, which honestly, it was not like that. I used to do a whole lot of single-piece IOLs also. So I wonder whether that health awareness has taken peak over the other unnecessary, foolish expenditures we've done in our life. I do not know. So then, if they cannot afford a toric, but they want a femtocataract, what do I lose by doing that arcuates? I would do an arcuate. I wouldn't even tell them I'm doing arcuates. I would do arcuates because I'm not going to charge for the arcuates. It's part and parcel of the femtocataract. And debulk the astigmatism to whatever extent I can for those femtocataract. But there are many patients who say they can't afford a femtocataract. It is 50,000 extra over above. But then we have all those Indian multifocals too in our practice. They are wonderful. The Indian torics are so good. So we go ahead and implant them.
So your choice, if there's no other things, it will be to go for a toric.
Toric, yes.
So, and obviously manual LRI is totally out.
Manual LRI is out, and
Yeah.
because there is wound regression, there is remodeling which occurs. So it is not there at all.
Anyone from the audience? Any question? If you don't have any, thank you so much, Chitra.
Thanks a lot.
You can
Thank you
carry
so
on.
much.
Yeah,
Thank
yeah.
you.
You can carry on with your other more important responsibilities. And now with this, we come to the next speaker, Dr. Vijay Shetty, a prolific surgeon, a great clinician, and a great phaco teacher. It's my privilege and honor to, present him to you, who's going to speak on newer presbyopic IOL. Vijay. Mike.
Good afternoon, everyone. At the outset, I would like to thank Dr. Haldipurkar sir and AIOCC Scientific Committee for giving me an opportunity to be a part of this IC. See, my topic for the day is newer presbyopic IOLs. So, the modern lifestyle requires us to to work at various working distances. So, correction of presbyopia following cataract surgery with conventional IOLs needs us to use bifocals or progressive lenses, which itself has its own set of problems. So there are certain options for presbyopic corrections during cataract surgery, which includes monovision using a monofocal lenses, or like we could use multifocal lenses, or we could use EDOF lenses. The multifocal lenses is mostly the diffractive or diffractive refractive lenses, which could be either bifocal or trifocal or quadrifocal technology. EDOF technology could be of various various varied technology, including wavefront, which includes elongation of wavefront, and the second is by using spherical aberration, and the third one is a refractive IOL, wherein a near ad is put in the lower segment of the IOL, and we could have a pinhole which cuts off the paraxial rays and gives a depth of field. And finally, a hybrid lens, which I mean here is a use of diffractive optics to create an EDOF lens. So technology used in multifocal IOLs are mainly diffractive gratings. These gratings, actually the properties of these gratings like step width and step height are used to modify the properties of the multifocal IOL. The narrower the steps give a higher ad power, and by reducing the step height, more light is given to the distance. This is used in case of apodization by shortening the height for peripheral diffractive gratings. Again, by changing the blaze angle of the diffractive gratings, you can create higher order diffraction, which is used in certain EDOF lenses like Symphony lenses. The most recent multifocal technology or diffractive technology is trifocal IOL. Here a combination of two diffractive gratings with two different ads are given so as to get a trifocal IOL. And finally, a quadrifocal technology wherein there is, instead of 3 foci, there are 4 foci, out of which the one foci that is at 120 centimeter is the height of these gratings are shortened to deviate this light to the distance. So distance gets more light and hence there is less dysphotopsia. At the same time, the intermediate distance is 60 centimeter instead of 80 centimeter. This is used in Alcon Panoptix lenses. Unlike multifocal lenses, EDOF IOLs have multiple technologies which are used. IOLs with certain attributes are defined by AO task force as EDOF lenses. So for an IOL to be called an EDOF, these attributes should be checked in monocular conditions. The mean distance corrected visual acuity should be comparable to the monofocal lenses. The defocus curve should be at least minus 0.5 diopter greater than the defocus curve for a monofocal lens for 20 by 32 vision. So this is, the blue line shows a defocus curve at 0.2 visual acuity, that is 2032. There is an additional depth of focus of 0.5 diopters. Distance corrected intermediate visual acuity, and that is done at photopic condition at 66 centimeter at 6 months, should be superior to the monofocal IOLs with a p-value less than 0.025. At least 50% of the patients implanted with EDOF lenses should have distance corrected intermediate visual acuity of 0.2 logmar units, which or better at 6 months. And the way the visual acuity is checked is also standardized, that like the the chart should have a illumination of 85 candelas per meter square. The defocus curve should be, the way the defocus curve should be done between 1.5 to 2.5 diopter is in a gap of, in a step of 0.5 diopters, and between plus 0.5 and minus 0.5, it should be checked in 0.25 diopters. The defocus curve should be stratified according to the patient's pupil size and axial length. So all kinds of eyes should be included when you are assessing a EDOF lens. The mesopic contrastic sensitivity should be performed at 1.5, 3, and 6 and 12 cycles per degree contrast. The EDOF lenses currently used are either wavefront based. Here there is an elongation of wavefront which is used in Vivity lenses, and there is an alternate positive and spherical aberration which is induced, which is used in case of Mini-Well lenses. And there is a refractive lens wherein a simple refractive element is added on the lower portion of the optics, and a pinhole lenses are also used for increasing the depth of field. And finally, a hybrid lens. I'll come to each one of these. There can be various strategies used along with EDOF to get better binocular vision, which includes micromonovision and mix and match. That is, two different kind of IOLs are used in each eye. Coming to mechanism of action of refractive IOLs, Oculentis Comfort is the lens which is used. This is a rotationally asymmetric refractive bifocal IOL. That means like it has to be placed in a certain orientation only. Lentis Comfort is the most popular refractive EDOF lens. The IOL orientation in the bag is crucial for successful outcome. Haptic with a single notch has to be placed in the proximal end of the cartridge when you are loading, and it has to be rotated either clockwise or anti-clockwise depending on which eye you are operating. And finally, the one with a single notch has to be placed superiorly so that the near segment is down. However, this Lentis Comfort was only able to give good intermediate vision but not good near vision. So there was an improvement over this lens. So then the evolution of M plus lens came into picture. So they started with M plus 2 with an addition of plus 2, and M plus 30 which had an addition of plus 3. However, this also had its own problems. So finally came the M plus X lenses. These had special features like surface design optimization with central extended near vision segment for pupil independence. That near segment came a little higher up in the periphery so that even in a small pupil it works well. And the small lens slit was used, that is around 0.7 millimeter instead of 1.15 millimeter in Lentis Comfort. And finally, an additive paraxial asphericity, which improves the depth of field and simplifies neuronal image interpretation. Although there is no intermediate focus with M+, there is a focal area that extends depth of focus. Combination of Lentis Comfort and M+ gives a continuous binocular range of vision, so giving rise to a continuous range of vision. M+ lens may induce vertical coma and trefoil in dilated pupil because of a large near ad, so it can cause angel wing halos as well. So then the next lens is the mini-well lenses. This works on the principle of alternate positive spherical aberration and negative spherical aberration. Here there are three zones. The central zone has a positive spherical aberration, paracentral zone has a negative spherical aberration, and peripheral has an aspheric zone. The zone 1 and 2 gives an extended focus which allows good intermediate vision. However, this lens also had the same problem that it gives you a good intermediate vision but only a fair near vision. So Mini-Well Proxa came in. Here instead of 3 zones, there are multiple zones of targeted spherical aberration are created to give a good near vision. So this allows a range of vision extending up to 33 centimeters or 3 diopters addition. So when implanted with Mini-Well and Mini-Well Proxa, the blue line shows that blue line in the defocus curve shows that the vision is maintained throughout all the distances. So the binocular vision is good when you use Mini-Well and Mini-Well Proxa in each eye. If you look at the photic phenomena, Mini-Well is comparable with the monofocal lenses and is definitely better than Symphony and Panoptix lenses. Coming to the most talked about EDOF lenses, that is Vivity lens. Vivity lens has got a separate mechanism of action. This uses X-wave technology wherein there is a modification in the central 2.2 millimeter zone. It has 2 smooth surface transition regime elements. The first one is slightly elevated, around 1 micron's elevation. It's a smooth plateau, and it has also a second element which is a slight curvature change. Both these elements put together gives a depth of field. So if you look at a presbyopic IOL, a presbyopic condition, near light is focused behind the retina with minimal depth of focus. When patient is implanted with VVT lenses, the central optics, the first transition zone helps in elongating the zone of forward, elongates the zone, and the second transition zone pushes it forward. So both the zones together gives a good depth of field, and that means good near vision and intermediate vision. If you look at if you compare VVT with panoptics, the near, intermediate and distance vision are comparable, although near vision is slightly better with panoptics. However, if you compare the photic phenomena, the VVT has got a much better profile in terms of halos and glare. Coming to hybrid EDOF lenses, that is wherein a diffractive element is used. Mostly it's used in symphony and synergy lenses. Here, the diffractive elements are modified in such a way that it gives a continuous focus or an elongated focus. However, certain limitations of the diffractive lens remain with such kind of EDOFs. With so many lenses available, choosing the right presbyopic correcting IOL is difficult. So we'll have to look at the patient requirement, patient expectation, affordability, and the eye characteristics. So identifying the patient's requirements and expectation includes to knowing about their routine activity and working distance for reading, driving after evening, current refractive status. Does he consider the need of glasses as a failure of the procedure, or are some halos acceptable? So when you choose, ask the patient if the patient considers need for reading glasses as considered as a failure, or habitually reads at a closer distance and needs to read at a lower illumination, then consider multifocal IOLs with a higher AD. If the patient requires to frequently drive after it becomes dark, or some degree of halos around a point source of light at night is completely unacceptable, then consider monofocals or EDOF lenses. Coming to the eye characteristics, if scotopic pupil is small and the patient wants a distance vision predominantly, then choose monofocal or EDOF lenses. If the pupil is large and then the patient wants distance priority, then choose EDOF or apodized multifocals. If it's a near priority, then multifocal IOLs with a higher AD should be chosen. And angle alpha and angle kappa also helps in deciding which IOL the patient should be taken for. So if the patient has a large angle kappa, then avoid lenses with a small optical zone. So use lenses with a larger central optic zone like Panoptix or Symphony, which has 1.1 and 1.6 millimeter optic zone. Multifocals with large central zone or EDOF lenses can be used in such patients. If patient has large angle alpha, it's better to go in for monofocal lenses. Eyes with dry eye, poor corneal topography, subluxated lens, glaucoma and age-related macular degeneration, these patients better to avoid diffractive multifocals and to some extent EDOF lenses as well. So before surgery, it is better to investigate the patients for dry eye, macular disease, potential visual acuity, corneal topography, and accurate biometry, and good IOL power calculation is mandatory for such patients. To exchange of information regarding the side effects of the multifocals, diffractive multifocals, and EDOF lenses like halos, glare, and starburst are necessary to get a satisfied patients. Finally, it's a balance between occasional use of glasses or the tolerance to this dysphotopsia that decides which IOL the patient should go in for. Thank you.
Thank you, Dr. Vijay. I just wanted you to tell me, how do you choose between EDOF, meaning VVT, and trifocal when you have a patient who can afford both in your practice?
So if the patients really insist on he is more into reading, especially the mobile and the text reading, then we would prefer trifocal IOLs over VVT. But if the patient is more into computer use and tablet use, then probably we would go. And he's more into night driving, then VVT would be better.
And probably if he also knows that sometimes he may need to carry
Even.
a small reading aid. Any questions from the audience? If no, then thank you, Vijay. It gives me pleasure to invite the next speaker, Dr. Tanvi Haldipurkar Venkatramani. She is a cataract refractive consultant at Lakshmi. And today she is going to speak on the role of dry eye in cataract surgery. Tanvi.
Thank you. Good afternoon, everyone. A topic as dry as the name suggests. I am hoping to infuse some juice into it and change our perspective and bring it to our clinics and how we can approach dry eye. So let's begin. As you will see further in the talk, dry eye is complex and it is a subjective diagnosis because there are several definitions to its names. A good place always is to start with the TFOS, that is the Tear Film Ocular Society classification, which tells us that dry eye is a multifactorial disease. It has a lot of problems, ultimately leading to a tear film instability, which is caused by which lands up with a hyperosmolar tear film, and finally ocular surface damage. Dry eye really is a conundrum because the pathology of the disease is still evolving. A lot is being studied about it and about tears and how they affect the ocular surface. But what we know is that a huge proportion of the population suffers from it. But a fraction of it is diagnosed and a small number is actually treated. Over the years, we know that it is not just the older population which is affected, but many young patients are now suffering it. And these are our prospective cataract and refractive patients. And if we misdiagnose them, our surgery will put them in a vicious cycle, causing tear instability and finally surface damage. This is an electron microscope image of the epithelium, and it is obviously not smooth. What makes it smooth is the tear film, and we don't truly appreciate the job that it does, and mostly we take it for granted. But we now know that a poor tear film will cause issues right from a poor optical visual quality. There will be problems in data measurements and then surface damage. I recently came across this hypothesis which helps us to categorize dry eye better. The tear film stability is equal to the tear volume, which is in turn determined by the tear production by the lacrimal glands and the evaporation that occurs and the outflow from the lacrimal apparatus multiplied by the corneal wettability. Now, this corneal wettability is dependent on the optimal functioning of the mucin hydrogel layer in the tear film, and that's something worth looking at in the future. So dry eye will then either be a dry eye because of aqueous deficiency or evaporative or mucin deficiency, which is causing the decreased wettability. So before it gets too dry, let's look at a patient who presented to us for cataract opinion. This is a 60-year-old female having minimal symptoms of dry eye, was on lubricants on and off, but had reduced quality of vision. Now, to be honest, in a busy OPD, sometimes we don't begin with tests of dry eye and jump directly into a biometry to plan for the cataract. This case is a great example of what can happen if we do that. So she underwent a Lenstar measurement as well as a Varion scan. It is always a good idea to look at multiple data points from different machines, because that's going to give you a clue for your astigmatism. Now here you can see the keratometry values from the two machines are not too different. It's a good idea to look at the raw data. There you can see the Lenstar raw reflections are seen because this validates your data. And you can see that the reflections are not precise. Some are darker than the others. Her keratometry on the topography was irregular and prominent on the tangential map. But surprisingly, the amount of astigmatism for her left eye was recorded as 0.2 versus the 2 diopters which was recorded with the other instruments. So a good clue for dry eye or tear film instability comes from with the same eye data when measured by 2 or more machines. Interestingly, we had a scan of this patient from 2 years back, and the cylinder in her left eye had increased from 0.5 to 2.5. Now, this change can only be explained by some change in the ocular surface from which the data is recorded. Obviously, her length of the eye hasn't changed. Although her symptoms were minimal, she had several clinical signs suggesting of a mixed type of dry eye with definite ocular surface damage. An ocular surface analyzer scan then helps to educate the patient about the tear film status. You can see here that the lipid layer on the osa was absent. We did have an access to an epithelial profile, and since tear instability ultimately leads to surface damage, we scanned her epithelium. And to both our dismay, this was her epithelium. It is thin, irregular, worse in the left eye, which rightfully showed the eccentric data measurements. And if the patient or even you are still not convinced, let's look at the eye tracy aberrations coming from the eye. The left eye in particular shows a reduced DLI, which was because of a cataract, but also a poor corneal visual quality, which was adding to the total visual blur. So just a cataract surgery was not going to solve her problems, but may even exaggerate them. So this cascade of scans began because we had a high index of suspicion when two machines gave slightly different values. We could have neglected those red flags, and then what could have happened is we would have used a wrong intraocular lens power, which would then have landed in a refractive surprise. You can see there's almost a 2 diopter difference. So changes in the tear osmolarity have shown to change the keratometry readings and to give inconsistent measurements. You can see here that there's a scatter of eyes which are more hyperosmolar as compared to the normal, and variability of up to 2.5 diopters is seen in some eyes. So that is the impact of the poor ocular surface on our cataract patients. You know that the dry eye affects the normal functioning unit, the effector and the effector arms, and what happens is it ultimately leads to an upregulation of cytokines and inflammatory mediators, which disrupts this cycle, leading to a surface damage. So our goal ultimately is to rescue this eye from this vicious cycle, and which is causing the damage, and to improve the tear film stability and to maintain the homeostasis. So the question to ask is, what can we do? To be a little philosophical, I can say, seek and you shall find. Dry eye or tear instability is almost always there until proven otherwise. Our lifestyles have changed since the lockdown. There is definitely an increase in the use of screens and the use of masks. Both have exaggerated the dry eye issue. This was a recent study done by Trattler, which showed that almost 76% of patients who presented for cataract surgery had positive corneal staining, and a big number of them had a tear breakup time less than 5 seconds. Now, that's a significant proportion of patients having dry eye. So a good approach to our routine practice would be to recognize it preoperatively and to take measures during and after surgery to keep the damage to the minimum. So tests for dry eye are many. We have added ocular surface analyzer and the ASOCT in our practice, as it helps us in managing them better. But certain dry eye clinics who specifically look at the tear status may also test for osmolarity, biomarkers, and corneal nerve testing. Now, this does give valuable data, but in practical use, they are really difficult to conduct and are kind of impractical in the current scenario. A good history, simply asking for medications that can reduce the tear secretions or increase the dry eye, like the antidepressants, anticholinergics, or even a history of smoking should be asked for. And of course, a good standard clinical examination can reveal a lot. There are several algorithms available today to avoid missing the diagnosis. This one is from Tear Film Ocular Society, or you can use the one given by ASCRS in this article. So once you've diagnosed it, it is very important to then educate the patient. A little increased chair time before surgery will help resolve this issue, because I'm sure that after surgery, if there is dry eye, they are going to associate it with your surgery. Now, reports like the OSA help to show the patient the layer which is deficient, and it helps us to target the therapy accordingly. And once a surgery is planned, we can then start a preservative-free lubricants, and in some cases of severe dry eye, even cyclosporin 2 weeks before to regularize the ocular surface. And use of preservative-free medication helps us to keep the homeostasis. And of course, we treat the dry eye if diagnosed. What do? We follow roughly the DEWS 2 protocol. We can use antibiotics, warm compress, secretagogues, or even intense pulse light therapy, depending on what type of dry eye the patient has presented with. During the time of surgery, using intracameral anesthetic and dilating medications can further help reduce the ocular damage, as repeated drops that are kept on putting before surgery can cause conjunctival cell damage. We can also reduce the light from the microscope while operating, or switch it off during instrument changes. Use of 2% HPMC has been shown to, to coat the cornea, has shown some protective effect. And when opting for LRI or any corneal incisions for astigmatism, we might counsel the patient preoperatively and treat the eye for a longer time with lubricants postoperatively. And of course, longer surgical times causes more drying and damage, and we should know this and be aware. Dry eye patients can be kept on lubricants for a longer time depending on their symptoms. There is definitely a role of these molecules, the cyclosporin, diacoazole, rebamipide, and sodium hyaluronate. So some of them are not in use in India as of now, but I'm sure that this will come soon in the future. And use of masks or sitting in front of the air condition can be counseled to the patient post-op because they may not face these problems before surgery, but this becomes exaggerated post. The last case that I want to show is of my refractive patient. He had come for Contoura LASIK and had moderate myopia with low Schirmer's and no symptoms for dry eye, except that his vision in the right eye was suboptimal as compared to the right. His clinical examination revealed signs of ocular surface damage, and the OSA showed a mixed type of dry eye. The ASOCT showed central epithelial thickening in the 5 mm zone, which was more in his right than his left. His topography on the first visit was fairly all right, but it did show some skewing. His topolizer scans were variable owing to the tear film instability. And he was advised dry eye treatment for 3 months. Now you can see the one on top is his the first scan, and the one lower down is the scan after 3 months. This was after 3 months of dry eye therapy. You can see that the bow tie has slightly regularized, and there was definitely a small change in the cylinder on topography. And this is his epithelial scan after 3 months, which was much more regular, and there was definitely less thickening of the epithelium. Now at this point, a decision can be taken to undergo LASIK or not, and this will give us a more predictable outcome. Now the change in his epithelium also reflected in his refraction when he accepted a cylinder of almost 1.5 and had a sharp 6/6 vision, which he didn't have before. So to conclude, I would say, seek and you shall find. Dry eye is almost always there. It is important to follow a strict protocol for every patient so you don't miss the diagnosis, and measure with more than one machine. This always gives a clue about the ocular surface. Stabilizing the ocular surface is of utmost importance in surgeries where the data is collected from the surface, like Contoura LASIK, even for your topography, even for the toric lens evaluations, because it will give us better results and disasters otherwise. Don't take the surface for granted. A good surface preoperatively does not mean a good surface postoperatively, which is why we need to counsel the patient. This is a list of preservative-free drops which I thought might be useful. And with that, I want to thank our audience and the panel for your patient listening. Thank you.
Thank you, Tanvi. It's a good talk. But then, have you in your practice noticed that in spite of all this, the incidence of dry eye in the patients after cataract surgery, have you been seeing often?
So if there wasn't before, it was probably not diagnosed by us, is what I believe now, because dry eye in the current scenario is always there. Maybe they just didn't have the symptoms for it. Post-operatively, I feel somehow that our patients, or the type of patients that we see, are quite less demanding in the sense that they don't really complain much. But I'm sure that if we go and check their tear breakup time 1 month after cataract, even 1 week after cataract surgery, it would be affected. It's just that they don't feel those symptoms anymore. But a good idea would be that the minute they say that I'm having a little bit of gritty feeling or a little bit of foreign body sensation, to go and maybe do a good dry eye workup and then start on these medications. So the quality will also improve for their vision.
Maybe sometimes if you kind of give them an idea,
Yeah.
that,
So counseling, I think, is
I'm
the
sure
way to
the audience would also have the same experience, that compared to practice in the earlier days, now post-op patients coming with complaints of dry eye are suddenly more than in the past. Has it been your experience, the audience? Anybody wants to share something? Yeah.
Hello. Well, partly I would tend to agree with her that probably the dry eye was there preoperatively also, but it was never diagnosed, and it only got exaggerated post-op. Now my one question is that in light of all this, can we ask the pharma industry to make most of our topical preparations in HPMC? Would that be of help?
So,
Because I think the toxicity due to topical use of eye drops continuously for 2 months post-operatively also is a contributing factor to the enhanced cases of dry eye. So can we ask them to make most of these formulations in HPMC? Would that be of help?
So I think that that's one point to be noted, because most of our drops do have preservatives, and they kind of do need to. That's probably the future. But obviously, the the cons of having a preservative-free drop in a society where, or in a place where the patients cannot handle them very well, might be the reason why they're not doing it so. But if we know about it, then there are certain options like I showed you in the last slide. They are available and in all types of molecules, so the steroids, the antibiotics, the lubricants. So if we know about the dry eye situation, we can then shift for those patients to those molecules. So that could be for now.
I get your point. Maybe it's worth, exploring this possibility of having most of the drops with HPMC to soothe the effect. Yes.
So I just like to share personal experience. I'm Dr. Kumar. I'm at Hinduja Hospital. Before this, I was at Moorfields. And my mother had a cataract surgery, 6/6 vision post-operatively, really bad dry eye. And I most probably was the most incompetent son she had for 6 months. So to the extent where she saw 4 people out here, ultimately I got fed up and I said, your surgery's gone very well. I sent her to Moorfields. I got her to see a lot of people there as well, David Gartry, and everyone saw her, and they said, oh, it's only dry eye. And what I'd like to emphasize to the audience is what you brought up is very nice. For us, it's only dry eye. For the patient, it is worse than having the cataract surgery done. For 6 months, I was hearing this drop is not working. I tried all the preservative-free drops there are in India. Then I got them from the US. Then I got them from UK. Then something called Hyalonite, which is just sterilized paraffin, worked wonders when she put it in at night. But these people get really symptomatic, and we tend to dismiss them. Till it happened to my mother, I had patients like that who would say, it's a bit itchy, and I'd say, you idiot, you have 6/6 vision, you should be happy and go away. But these people get very symptomatic, so I think you're absolutely spot on. And I've experienced it. It was a year before she kind of, said, okay, maybe I'll, won't disown you from my will. So it's a dangerous thing.
Thank you for sharing that. The paraffin drops would be an interesting thing for Indian farmers to pick
there
up.
are patients who come to say, you give me back my cataract. I was much better before that. No, what is the cause? Why it become such a blown up, and in some cases it becomes permanent, not temporary?
So it's a problem of that cycle that I showed you. So what happens is that there is tear instability. That instability is causing a lot of problems with the corneal nerves there. So the effector arm, which is ideally supposed to go back and tell your ocular functional unit that let's send in more tears, it stops. So there is no dilution, there is no tears coming in. So there is again a tear hyperosmolarity and then damage. So there is never a break in that cycle. So I think that as clinicians, we can always look at it. It may be a mild dry eye, but the minute we start a lubricant or any kind of treatment, we are breaking that cycle and then restoring the normal. So I think that hyperosmolar tear. So a lot of studies are being done about tears, and they are learning about the inflammatory mediators that are in there. That's a little far short for a private practitioner like us. But if we understand that we need to break this cycle and then treat them accordingly, that's going to tremendously make a change. And we have seen this in a lot of our patients. The minute we start, a lot of things regularize. We have studied their epitheliums, which do get better, and definitely a better visual quality has been seen.
You mean to say we should get the tear analysis done?
No, you don't need to, sir. This is just for me to show that, yes, I clinically saw it, and then it corroborated with the scans.
Like doctor had pinpointed some drop,
Yeah,
Can we
yeah.
pinpoint something like that?
So I do like to use a lot of, the DUCE protocol for treatment like you saw, it's very exhaustive, we can follow it. But what I've also seen is that if you diagnose what type of dry eye it is, if it's a meibomian gland one, maybe a lipid supplement is something that I have seen which works very well. Not many secretagogues that I have really prescribed, but sodium hyaluronate also seems to work quite well. And cyclosporin also is a main factor in my private practice that I have given to my patients and seen the ocular surface regularize.
It's very, very frustrating. You did a beautiful phaco, nothing you see, the patient is always unhappy.
Thank you, Dr. Tanvi. Now I invite Dr. Suhas Aldipurkar sir to speak on his topic. He does not need any introduction. He is one of the greatest phaco teachers who has taught surgeons across the globe. I am fortunate to have learned phaco from him. his topic for the day is what new things I do in the operation theater for last 1 year. So this would be a video-based presentation. So I request Haldipurkar sir to take over and speak.
Thank you, Dr. Vijay. Well, this course, in the first place, was, thought of 2 years back, where we wanted to, because we had time, we thought we'll come out with what are the new things that we learned. But since the title has continued, but what I thought in this particular talk of mine is to bring about to you or share with you some of the very simple steps that I added in my day-to-day cataract surgery with very specific reasons, and I achieved all that. And I was very happy I have added those, and they definitely make my surgical results more precise and better. Now, first of all, I changed my side ports from bimanual to coaxial. So naturally, my side port from 1.1, I brought it down to 0.8 stab. Now you'll wonder why 0.8 stab? Because when you use your bimanual and you use your chopper comes in different sizes. Some are bulky, some are very narrow. And when you use a narrow one, there's a lot of leakage happening. There are machines which can take care of that leakage because those machines are so very sensitive. But most of the machines are not even aware that so much of fluid is going out from the side port. And that tends to make your chamber shallow. It's not working. Hello? It's not working. So this is a stab incision of 0.8, and I stopped using forceps, and I use a soft stick simply because, I don't want to have any subconjunctival hemorrhage there. Then I started making a groove before entering so that my external lip was more clean and there were no frayed edges for my external lip. Then I changed my style of doing my wound closure. And this is where what you noticed me doing was after I hydrated the floor of my wound, I'll just go through it again. See, that is all the amount of hydration I do. Here I'm trying to press the lens back because very often, see the hydration that I do, it just hydrate the floor and that just seals it. So you don't have the cornea becoming white because of wound hydration. And because the side port is very narrow, very often I'm sure you have noticed when you have really made your chamber firm, the wound is sealed well, but the AC still looks shallow because the lens is still not back into the original position to be at the posterior capsule. At such times, if you go with your side port, with a spatula through the side port and press on the lens, and you can literally see it pushing back and the AC deepens, and then you again rehydrate the floor and it gives you a very deep chamber. One thing that I picked from these webinars is from one surgeon who made it a point to rotate the nucleus clockwise and anti-clockwise 3 to 4 times, and I practice it, And I have realized, I have seen some of the benefits of, getting your cortical aspiration easy and complete. With regards to bimanual eye, I changed and modified it. I'm very conscious about my side port, the wounds getting disfigured. So I don't cross the midline. If I'm using bimanual with irrigation on the left hand, now irrigation is from the right. What I do is, I just stay on this side of the midline. I'm very, very cautious. So by doing that, my side ports are preserved so well that after I put the lens, see the amount of hydration that I need to do. You just inject a drop or two, and your eye is firm. And then I go with the antibiotic. And to inject antibiotic, I stay outside. I don't even push my thing in, and the eyeball is firm. I have stopped doing wound hydration in last 2-3 years. And it's possible if you preserve your side ports. Normally, we do our implantation under viscoelastic. Some do it under hydration. The reason for doing it under hydration is that you don't need to spend time doing your visco removal. So I decided to go for a hybrid lens implantation, where what I do is, I inject very little amount of visco in the eye. Now I have just flushed it. Very little visco. And that's all it is. I go with the 2 cc, go to the extreme end, inject hydro to fill the bag. While doing that, some of the visco has come out. And here through my side port, the fluid does not leak because it's a 0.8 side port. After you have implanted your lens, because you have a triplanar wound, even that doesn't leak. And the small amount of visco that you have put is enough for you to get your lens inside. Now, under the lens, normally there would be a lot of visco remaining, and you need to spend a lot of time washing it out. Here you don't need to do that because the amount of visco that's there is not much. But as a customer, I always prefer to go under the lens, because one of the reasons for early PCO or fibrotic PCO is some of the muck that stays underneath. Even if there's no obviously much of viscoelastic, it's always better to flush under the lens. And then, now this is how all of us, place our toric lens in the desired position. Here you don't see the mark because it is done under Varian, markerless. So I'm seeing the marks, but the video doesn't capture it. But it is possible. But sometimes this easy step is not possible. Your eye is not able to rotate the lens to the desired position. See again. So what it does is, it just hydrates the wound, and quickly the two lips close, and you have a firm eyeball. When it comes to toric implantation, if my IA cannula is not able to get the lens in the desired position, after I hydrate my wound, I make another stab, which is around 0.5, just a small entry, just enough for my Sinskey to go in. So the Sinskey, once it is in, there's no fluid leaking out. So the AC remains formed all the time, and I can take my toric to whatever axis it needs to go, and the AC never collapses, which you can never do through a side port of 1.1, because the moment you go with your instrument, the AC collapses and you have to refill it. Here, till I get my lens in the desired axis, the AC remains formed, and once the lens has reached the marks, these marks I had to specially make so that in the video one can see them. Till now, the AC is formed, and I have my lens in the desired position. And then, as a completion, I again inject some fluid, meaning I do floor hydration. I check whether the eyeball is firm. It is not. So a little bit of fluid. And then I take my spatula and press the lens back, because I realized that lens was not fully placed posteriorly. And especially for a toric lens, sometimes you know the lens is in the exact axis, but that axis of the lens and the two markers on your marker lens, they are parallel to each other, and there's bit of parallax. At such times, if you go through the side port and press the lens back, sometimes that parallax closes and the lens is more aligned with the Varion markers. Now, this is a very common picture with most of us, especially when you have a floppy iris. And what we normally do is, you push it back with the irrigation stopped, and then the second thing you do is hydrate the wound. Sometimes it works. And the third thing you do is start irrigation only when you reach in the middle, but sometimes it doesn't even work that way. So here what I do now, so this is another step that we do, that we inject some visco near the wound and hope to keep the iris back there and work, but even there sometimes it doesn't work. And the iris just refuses to behave properly. So a small tip that I can share with you is go with the spatula, keep the spatula there, then go with your irrigation, and now the iris cannot misbehave. Now these are tips which I'm sure would help you. This is something I've been doing for quite some time. Whenever I have a posterior polar cataract, what I do is called in situ four quadrant. You can do it better if you have a bent tip. Here you have not done hydrodissection, so your nucleus cannot be rotated, but you can certainly do your four quadrant in this style, and it's easily possible. You can deepen your trenches, and once one particular quadrant crack is achieved, you can go and do the further cracks in this manner. For example, in cases where nucleus rotation cannot be achieved, even if it is not a posterior polar cataract, this technique works for me all the time. And the indication for doing this, using this technique, is non-rotation of the nucleus. And what is left is just the posterior plaque. Finally, go with your chopper and lift it up. And finally, what you're left is the posterior plaque. So this was another simple step I thought I would share with you. And unlike what Dr. Chitra said, LRI is definitely an integral part of every cataract surgeon. We do toric practice, and we also have patients who would benefit from a cylindrical correction, and for monetary reasons they cannot go for, and for them LRI is an option. To me, LRI is done in the following manner. I complete my case, do the hydration in the way I have shown you. Then, with the help of my markerless marker system, first I mark the steep axis. Then, by NAPA program, I assess the size of the arcuate arc, then measure the depth of the peripheral cornea, set my diamond knife, and do your LRI in the desired steep axis, and it works well. And it is something I'm sure most of you do, but if you do not, please start with it. And few LRI pearls, that's my last slide. LRIs can produce a hyperopic shift of about 0.2 diopters, so it is advisable to choose a higher powered lens than is suggested by the IOL power calculation. Any bleeding from corneal neovascularization can blunt the desired flattening effect of LRI. A slight undercorrection can instantaneously be adjusted by creating a new LRI central to the existing one or lengthening the existing LRI. If an overcorrection occurs, wait for 2 to 3 months before any action. Thank you so much. If you have any questions, we'll be very happy to answer. Yeah.
Hello, sir. Is it working? Yeah. Okay, sir. As always, very inspiring surgical videos. I just had one question regarding the in situ 4-quadrant technique which you showed. Do you think that the same technique can be done with phaco equipment which do not have either torsional or elliptical phaco?
I do it with my Oertli, which is a straight and a conventional.
Okay, only simple conventional
Yeah, you can.
phaco
Yeah.
can do.
Just the bend tip makes it more efficient, especially for the upper cracks, but all the 3 cracks, it's possible. And then the trick is, after you've done that, you take a chopper, go sweep the upper nucleus and just nudge it down, and then crack. Thank you so much.